So welcome to our ACCP Ambulatory Care Journal Club. We are very pleased to have two pharmacy residents helping to facilitate our journal club today. So my name is Kylie Funk, and I've been helping on behalf of the Education Committee and with the Education Committee to organize this. And today we will start with Yvette Zeng. She is a PGY2 ambulatory care pharmacy resident located at Texas Tech University Health Sciences Center. And she will be presenting on Association of Office and Ambulatory Blood Pressure with Mortality and Cardiovascular Outcomes article. So she will have a 20-minute presentation, and after her presentation, we'll have about 7 minutes for question and answer. And the question and answer will be completed through the chat mechanism in Zoom. So if you scroll to the bottom of your screen, you should be able to see chat, and when you click on that, you can chat in a question to everyone. And we will have one of her mentors, Eric McLaughlin, will be facilitating that question and answer session. And after Yvette's presentation, Stephanie Witek, who is a PGY1 pharmacy practice resident at the Hospital of the University of Pennsylvania in Philadelphia, will be presenting on oral semaglutide versus subcutaneous liraglutide and placebo in type 2 diabetes, which is the Pioneer 4 trial. And so thanks again to Yvette and Stephanie. And I will go ahead and hand over the floor to Yvette to start her presentation.
All right, thank you for the introduction, Kylie. Just want to double check. Can everybody hear me and see my slides?
We can.
All right, great.
Just as a note for all those listening, you're automatically on mute, all of the people in the audience, and so you feel free to chat in your questions. Okay, thanks, Yvette.
All right, thank you. Okay, so we'll go ahead and get started, but my journal article, as it says, is looking at the association of office and ambulatory blood pressure with mortality and cardiovascular outcomes. So just to start off, I have no actual or potential conflicts of interest to disclose. And we'll start off with a little bit of background. So of course, with our different blood pressure measurements, the disease state that we are targeting is hypertension. Just so you have an idea of some recent data that we have in terms of how much of our US population is doing in terms of prevalence and control. Of course, we had the recent 2017 ACC-AHA guidelines, which have different blood pressure thresholds, but these two charts help to give you an idea of just how prevalent the disease state is and the control is based on just having the previous JNC7 and then the addition of the ACC-AHA guidelines. So you can see on the chart on the left-hand side that just over or just under half of our patient population has hypertension as a diagnosis. But when we actually look at how many are on therapy and then how many are, so to say, at goal, we have less than those who are diagnosed on actual pharmacological therapy. And in terms of control, we have over half of these patients above goal. So this is an area of interest for a lot of accountable care organizations in using hypertension and control as a quality metric. So just to provide a little background information on the different types of monitoring that we have three types that we are going to be focusing on. So the two that many people may be most familiar with are the office or clinic blood pressure as well as the home blood pressure monitoring. So as the name suggests, with clinic and office blood pressure, it's a blood pressure that's taken by a healthcare professional within a medical environment. Home blood pressure monitoring is probably the one that's most commonly known as an out-of-office blood pressure reading, in which the patient takes a machine in their house or outside, and they take that one blood pressure reading for a particular point of time. As we get into ambulatory blood pressure monitoring, which has been cited in the guidelines, but from my knowledge, not very well known or utilized in a practice setting, the difference with ambulatory blood pressure monitoring is that we utilize a device that helps to take a patient's blood pressure over a 24-hour period. So it's not recording just one point in time, it is over a 24-hour period. And essentially we can get a map of patients' blood pressures, their fluctuations throughout the day. We do know that there's a diurnal pattern with blood pressure. Particularly, we note that there should be a decrease in blood pressure around the nighttime setting, which has a protective effect. So we also take into account dipping ratios, which looks at the proportion of what the nighttime blood pressure is compared to daytime. Typically, normal dippers will have a decrease in blood pressure of about 10%. Non-dippers, they do not meet that threshold, and reverse dipping, they actually have an elevation in blood pressure at nighttime. This is just a little schematic of what you may see in terms of an ambulatory blood pressure log. You can see that is conducted over a 24-hour period, and we have fluctuations that you can mention throughout the day based on different events or nighttime versus daytime. So now we're going to be getting into the actual journal article itself. So as I mentioned, this is looking at association of different indexes with the endpoints of total mortality or a composite CV event. This is a longitudinal population-based cohort study that was conducted in multiple countries, and it was conducted over about 30-year period. So we'll get a little bit into what exactly the conventional, automated, and ambulatory blood pressure indexes are defined in this study. So in terms of what the assessments were for the 3 different types of blood pressures, the one that we are focusing on is the ambulatory blood pressure monitoring. So they have set intervals of how often blood pressures are taken during the daytime and the nighttime, with the nighttime readings being a little bit spaced out more. Another thing to note is that there were set times depending on the country of when it was considered nighttime versus daytime. In order to be eligible for analysis and to be included in the study, patients had to have at least 6 daytime readings and 3 nighttime readings. And in addition to the readings and the averages, they also looked at dipping ratio, which is defined as such on the slide. As we go into automated blood pressure and conventional blood pressure, there's a slight difference between the two. When we think of automated blood pressure, we often think of the automated machines that may be used in clinic to take a blood pressure reading, but that's actually considered the conventional blood pressure over here. So conventional can be also thought of as the office blood pressure reading, so using a standard device, the handheld device, or a validated oscillatory or oscillometric device. It is taken in an office setting, and that is recorded as the patient's blood pressure. For automated blood pressure, according to this study, it's actually using the ambulatory device in the clinic setting. So they average the readings that are taken within the first hour in that medical setting. So that's what's constituted as the automated blood pressure. So we have these different readings that are going to be looked at and studied in terms of what is the association with total mortality and cardiovascular outcomes. Just to go into the study methods a little bit, there were a number of different tools and methods used in order to obtain the results. So to find out the normality of distributions, the Kolmogorov-Smirnov test was used. For a comparison of means, the large sample Z test was used, in particular for the blood pressure indexes and readings, whereas comparison of proportions were analyzed using the Fisher exact test. There were a number of adjustments to be made for depending on what the other blood pressure readings were, as well as sex, age, other cohort characteristics, which I'll get into a little bit later. And while they did try and include as many patients as possible that were eligible for inclusion criteria, if there were any missing values, in particular BMI or unknown past medical history or social statuses, which will include smoking status or drinking, they used different methods in order to account for those missing values to try and account for them. So now looking into the results of the study. So they included over 11,000 participants and excluded just under 2,000, with those exclusion reasons being that patients were of adolescent age or they did not meet the minimum criteria for having the 6 daytime readings or 3 nighttime readings. When we look at the age of these patients, median age is about 55 years old, and it's evenly split between men and women. Most of the population was of European descent, and in terms of follow-up, patients were followed for a median of about 14 years, but we do have a range of 2 to about 23 years. So now to look at the baseline characteristics of these patients. So this is not all inclusive, but I want to bring your attention to a couple of risk factors that would otherwise affect some of our results and our thoughts on what their blood pressure readings are. So some of the ones I want to turn your attention to are just comorbidities. So you can see in terms of the population having hypertension, just under half of them actually had hypertension. And of the whole population, only about 1/5 of those patients were on antihypertensive treatment. Another thing to note is that this is the only area in which the study looked at antihypertensives. No detail was given in terms of what the classes were, doses, and the treatment changes as well. It was only recorded at baseline, which could affect our results. Even less of the population had diabetes, and just about 12% had a history of cardiovascular disease, all influencing factors for elevated blood pressures. I also want to turn your attention to some social factors which could also possibly elevate blood pressure, which includes current smoking and drinking alcohol, which you can see a large portion of our patients, over half, drank alcohol, and just about under 30% were current smokers. And to look at the averages of the blood pressures, so again, we have our conventional blood pressure, we have our automated office blood pressure, and then we have our ambulatory blood pressure readings, which are actually further divided down into 24-hour average, daytime average, and nighttime average. So you can see for the office readings with conventional and automated that the average systolic and diastolics were higher than those that were taken from ambulatory readings. We can note that at the nighttime, we do have a lower reading, which shows that there should be a lower dip when it comes to the nighttime blood pressures. So now that we looked at our baseline characteristics and have an idea of the average blood pressures, I would like to turn your attention to the results. So this table over here shows the association of the outcomes. In this case, I'm concentrating on total mortality for this particular table with 24-hour readings or nighttime systolic blood pressures. As we know, systolic blood pressures have a stronger correlation with health outcomes. So as we can see over here with conventional and automated office blood pressure readings, any elevated readings were associated with a 12% increase in total mortality for conventional, an 8% increase for automated office, and we can see that the confidence intervals do not pass 1, and they were all found to be statistically significant. As we look at all of our ambulatory blood pressure readings, whether it be 24-hour, daytime, or nighttime, these were even more so at an increased risk of having that endpoint of total mortality. So 22% if you had elevated 24-hour reading, 14 for daytime, and nighttime 23. We can also see dipping ratio as well. We have a 13% increase in meeting this total mortality endpoint if they were, so to say, a non-dipper. As we look at cardiovascular outcomes and what the association is with the different blood pressure indexes and cardiovascular outcomes, we can see we still have an elevated risk of meeting that outcome. Which cardiovascular outcomes, what they included was MI, stroke, heart failure, in addition with cardiovascular mortality. So we can see that we still have an increase in 20% meeting that endpoint with an elevated conventional reading compared to automated, which has 19%. And as we look at the ambulatory readings, again, much higher numbers when it comes to elevated readings and meeting that primary endpoint. And we can see that all of these were found to be statistically significant as well. Ooh, excuse me. And then these tables over here are just different associations, and these were adjusted for blood pressure indexes. Excuse me. So as we look at the adjustment for 24 hours in relation to conventional, once conventional blood pressure readings were adjusted for the 24-hour readings to make sure that 24-hour readings don't have an effect on conventional, we can see that there's an elevated risk of meeting total mortality when we have elevated conventional readings. The same is the case for automated office as well. And again, with our ambulatory readings, we have an increased risk. You can see for the nighttime readings, there's actually found to be non-significant elevation when 24-hour blood pressures were accounted for, but still the same case for dipping ratio. As we look at the nighttime readings, again, adjusting for nighttime readings, making sure that these readings do not have an effect on the blood pressure readings on the left-hand side, there's still an elevated risk of meeting total mortality. So a 20% increase with elevated conventional readings meeting total mortality, and you can see the other values for the remaining types of blood pressure indexes. This one just shows the other primary endpoint, which is the cardiovascular outcomes, but just to summarize, again, we can see that there is an increased risk of meeting that primary endpoint of cardiovascular outcomes, even more so with all of our readings. So elevated blood pressures have a 40% increase for conventional elevated readings when accounting for 24-hour adjustments, 47% for automated office, and then even more so for daytime readings and dipping ratios. So this is another analysis that the journal authors did, and they looked at 10-year risk of total mortality based on incremental increases in the systolic blood pressures of either 24 or nighttime blood pressure readings. So we can see that as we go up in terms of increasing the systolic blood pressure for nighttime readings, the 10-year risk of meeting total mortality also increases. So if the systolic blood pressure at the nighttime is found to be 140, we have a 5.35 10-year risk of total mortality being met. With the 24 systolic blood pressure, this is actually found to be non-significant in that there's actually a decrease as we have an increase in the systolic blood pressure for 24 hours. And finally, looking at cardiovascular outcomes with the 10-year risk, we can see again that as we continue to have elevations in blood pressure for nighttime or 24 systolic, there's also an increase in meeting a cardiovascular outcome with, at the worst point, you can see that there's a 7.82% 10-year risk of cardiovascular outcomes. So the author's conclusions to the study were that higher nighttime and 24-hour blood pressure readings were associated with higher rates of mortality and cardiovascular outcomes. And so as a result, these may be considered for estimating cardiovascular risk. However, because they also compared it to other blood pressure indexes, we can see that those were also indicative of meeting those primary endpoints, and that there may need to be some model improvement in order to consider these for actual measurements. So some considerations and points of critique for this journal article. So first thing I would like to bring up is blood pressure measurement technique, which we know is an important part of having an accurate blood pressure measurement. This is in particular talking about the conventional and office readings that were mentioned. They talked about having validated devices and having a correct cup size, which are certainly components of having an accurate blood pressure reading. However, other points such as making sure the patient is in an appropriate position, not talking, legs uncrossed was not talked about, and so there might be some possible discrepancies in the blood pressure readings that were reported. The diary approach was not utilized. So this is an approach that is primarily used in the ambulatory blood pressure setting. So what happens is that patients will actually have a diary of what times of wakefulness they are in and what times are considered their night times. The study used very specific points in time at which they considered daytime versus nighttime, and actually may not be reflective of the patient's actual activities. And so as a result, it may not be an accurate reflection of what is a patient's true nighttime affecting the results. I did talk about this a little bit in terms of the hypertensive treatment details. So there were no details that were mentioned, and it was only recorded at baseline. And if there were any changes to treatments that could have, again, affected the blood pressure readings, whether they start to become at control and therefore at decreased risk for those outcomes, we're not sure of those details. And finally, all blood pressure readings, the conventional office, the automated office, as well as all the ambulatory care blood pressure readings, were predictive of outcomes. So even if an institution does not have ABPM at their disposal, having an elevated conventional office reading may still be predictive of actual outcomes. So now just again to some practice considerations. So billing for ambulatory blood pressure monitoring. So the Centers for Medicare and Medicaid Services recently updated their decision-making in terms of covering for this service. So recently they only had one diagnosis in which they may consider covering ABPM, but they recently expanded it as of the middle of last year to these two indications. So if a patient has suspected white coat hypertension or suspected fast hypertension, but there are specific criteria to meet, which you can see listed on this slide. So if there are any eligible patients based on these suspected diagnoses, it is covered once per year. And there are variable amounts in terms of reimbursements depending on the practice area as well as the insurance plans. So Medicare covers this as well as some private insurance carriers. And just to get a little bit more into the billing aspect of ABPM, there are different CPT codes that can be used to bill for the service. The recommended one is this 93784, which includes a lot of different actions that you can take, including recording, scanning, interpretation reports. We do have other CPT codes that may be utilized that specifically focus on one action, but recommended global is to do all of these actions if you are utilizing this device anyways. And then ICD-10 code that is most prominently utilized would be this elevated blood pressure reading, R03.0, but other diagnoses in relation to hypertension may also be used if billing for this service. So these are just some additional resources because my background introduction was very brief, but you may feel free to go to any of these sources to learn more about ambulatory blood pressure reading and the decision memo behind CMS covering ABPM. I would like to acknowledge my mentors, Dr. McLaughlin and Dr. Kerwin, who were an essential part of putting this presentation together, and I could not have done it without their help and guidance. And that concludes my journal presentation. So at this moment, I will take any questions or comments.
Thank you so much, Yvette. And so as a reminder, we will be doing questions through the chat function in Zoom. And so at the bottom of your screen, everyone's screen, they can see chat. Please feel free to type in your questions that you might have for Yvette now. And I will hand it over to one of her mentors, Eric McLaughlin, to facilitate these next couple of minutes of questions.
All right, thank you. Hopefully everyone can hear me okay. If anyone has questions they'd like to pose, again, feel free to put in the chat window. I did have a couple questions, maybe while folks might be formulating thoughts or questions on their own. Yvette, you know, obviously the study here was pretty compelling evidence to incorporate ambulatory BP monitoring into routine practice, and obviously with a lot of the political support that's happened over the last couple of years to get billing codes and improved reimbursements, I think you're going to be seeing more of this. But I was wondering if you could comment on maybe what you see as maybe some of the biggest challenges in incorporating ambulatory BP monitoring incorporating it more into routine clinical practice.
Mm-hmm. Yeah, absolutely. Thank you for the question. So as I mentioned, ambulatory blood pressure monitoring has been cited in guidelines, and it's well known in terms of having literature and evidence supporting it, but it is not widely seen, at least to my knowledge, in practice. So to my understanding, some of the possible barriers that could prevent the service from being more utilized, I think one of them is just working with the patient. So I think because this is a 24-hour log that would be recorded for the patient has to wear the device for that period of time and have those measurements taken every so often. Some other things that are to be noted with this ABPM device for patients is that there are certain restrictions, such as they're not able to bathe or shower for that period of time or do any extensive exercise as well. So a big component of this is being able to work with the patient and making sure that they would be open to utilizing the device. And if they're not able to, then we wouldn't be able to get those blood pressure readings and then as a result make adjustments to therapy. So I would certainly say one of the big barriers that could be presented is just being able to work with the patient and if they are open to having those restrictions and wearing the device for 24 hours. I would say maybe on the practice side, another thing is possibly knowledge of ABPM. So I'm actually at my current practice site implementing a new protocol to utilize this device in our clinic. And thus far from the responses that I've gotten, quite a few providers, especially resident physicians who are just learning and going through the training, are unaware of ABPM. And so knowing how to utilize it, which patients would be appropriate, I think there's also a gap there that we can help to address. And as a result, if we kind of focus on these certain measures, then we could certainly increase the service and utilize it more for our patients.
Thanks, Yvette. I don't know if we have any other questions. There's a question we got in the chat box that I'll kind of read off here. When automated office BP monitoring is performed in the clinic setting, does that involve serial measurements and then does that average them?
Right, so I think in terms of the automated office readings, so to my knowledge and my research, this is actually not a common practice to utilize the ABPM device and take those measurements into account when you're using the device. If we are using the ABPM device within the clinic setting, I believe it's more so just to ensure that the machine itself is working. I can also see that there might be implications of making sure the device is working. If it's still elevated with this device versus the clinic device, so to say, there may be some implications there in terms of what is the purpose of having an automated office reading. But like I said, to my knowledge, I think this isn't a common practice, just more so to ensure that the ABPM device is working before we send a patient off to go about their daily schedule and get their blood pressure readings that way.
And I'll kind of just chime in a little bit as well. I mean, I agree with you. In the current study, it was interesting. They didn't really, I think they used correct me if I'm wrong, they used an ambulatory blood pressure monitor, but they did it in the clinic and they did the averages, which is a little different, I think, than the usual AOBP measurement monitoring. I think that's kind of what they did in Sprint, I believe. And a lot of times it does average those automatically for you and will show a little bit lower. So they used a little bit different, again, correct me if I'm wrong, I think they used a little bit different technique here. Mm-hmm. I don't know, do we have time for one more question?
I think there's time for one more question. It looks like there might be one in the chat. Yeah.
Alvin had asked if, a really good question, if ABPMs are unavailable in the clinic, do you think the data is enough there to support nighttime dosing of BP meds over daytime dosing? I think he's getting at the Hygia chronotherapy trial. It seems there might have been a trend towards poor outcomes when nighttime readings were elevated.
Mm-hmm. Right. Yeah. So just to touch base on that particular trial, which I think just recently came out. So I think that there was an association with the poor outcomes about the nighttime dosing, but I think there were some also limitations to that study, which included the population. I believe this was a primarily Spanish-based population. I think also in terms of the antihypertensives that were used, I think the classes that they concentrated on were the calcium channel blockers versus some of our other first-line agents such as ACE inhibitors, for example, or our thiazide diuretics or thiazide-like diuretics. So I think there were a number of limitations that, although there was that associated outcome, also proved points of what's the generalizability and can we actually apply this to our population in the United States?
Yeah, I kind of agree with your thoughts, and it's a really interesting paper. I like to see, and the outcomes were really, really could be significantly practice changing. I would like to see this replicated though by outside groups. Personally, this is kind of my own take as well. Because some of the other trials, like if you look at the Covera HS, the Convince trial, which was stopped prematurely, you know, the coronal therapy didn't really improve hard cardiac outcomes, but this one was pretty pronounced. So it would be interesting to see how other groups, if this trial can be replicated and address some of the limitations that Yvette talked about. So with that, to keep us on track, I think we'll wrap it up and maybe go to the next presentation, I guess. So thank you very much.
Thank you, everybody.
And thanks once again to Yvette Zeng and both of her mentors, Eric McLaughlin and Lara Kerwin, who helped in her presentation. So now we'll transition over to Stephanie Witek's presentation. Again, Stephanie is a PGY1 pharmacy practice resident at the Hospital of the University of Pennsylvania. And so I will hand over the floor to Stephanie. And as a reminder, please feel free if you're thinking about questions as she is presenting. Her mentor, Logan Frank, will be monitoring those questions and then we'll be posing them to her during the Q&A session. And so feel free to chat in your questions as they come to mind. Okay, Stephanie, the floor is yours.
Okay, thanks, Kylie. Hi, everyone. My name is Stephanie Witek. As Kylie mentioned, I'm a PGY1 pharmacy resident. Today, I'm going to be discussing the Pioneer 4 trial, which was oral semaglutide versus subcutaneous liraglutide and placebo for type 2 diabetes. I'd like to start with some background. The glucagon-like peptide 1, or GLP-1, is an endogenous peptide hormone that's released by intestinal cells in response to nutrient consumption. As you can see with the graphic on the right side of the screen here, there are many effects that GLP-1 can have on various areas of the body. The most notable effects that we think of in regards to type 2 diabetes, though, are the decrease in appetite and slowed gastric emptying. But there's also effects thought to affect insulin secretion, insulin expression, and so on and so forth. We know we have analog agents that have demonstrated effective reductions in A1C, body weight, and even cardiovascular risk. But that's only for select agents. Also, all of our available agents have been subcutaneous injections. The ADA recently updated their standards of diabetes care, so this graphic is taken directly from their guidelines. You can see in the yellow boxes here all of the different scenarios where a GLP-1 agonist might be recommended for a given patient. Notably, the update this year is that in addition to metformin first line, if a patient has a compelling indication such as risks for cardiovascular disease, it would be recommended to start a GLP-1 agonist at that time, regardless of their A1C. But even beyond those compelling indications, if a patient needs additional A1C lowering that's not controlled with metformin and lifestyle changes, you can see there's other scenarios where you would use the GLP-1 agonist as your next line agent. So it's a very frequently used class. As I mentioned, with previous agents only being available as an injection, the development of this oral product is really novel. Peptides have low oral bioavailability for a few reasons. One of those being that they are easily degraded by proteolytic enzymes, and also that they have poor gastrointestinal mucosal absorption, likely due to their large molecule size. Oral semaglutide is co-formulated with an additive known as SNAC, which is quite possibly one of my favorite acronyms ever. And SNAC is a fatty acid derivative, so it's highly lipophilic. You can see at the bottom of the screen on the left-hand side is the semaglutide molecule, so very large, and on the right-hand side is SNAC, which is clearly going to be more lipophilic. So the idea behind SNAC is that it'll facilitate passage across the gastric epithelium through lipophilicity, but it also is thought to locally increase the pH and protect the semaglutide molecule from proteolytic degradation in the acidic environment of the stomach. There's a series of pioneering trials that have been published. There's also 2 that I believe have just had their update released on the clinical trials website, but they haven't been published yet. So I've outlined here the 8 that have been published for your reference if you'd like to look back at them at any point. Most notably, Pioneer 6 was the only one that had a different primary outcome. The rest of them looked at A1C lowering, but Pioneer 6 was the cardiovascular effect trial. The primary differences between each trial was the comparator arm and then the background therapy that patients were receiving for their diabetes. Like I said, I'll be focusing on Pioneer 4 today because it's comparing to an active comparator liraglutide, but I would like to mention that Pioneer 6 did demonstrate that there was no cardiovascular benefit for the oral product. Moving on to the specific details of the Pioneer 4 trial, it was a randomized, double-blind, double-dummy, active and placebo-controlled, multi-center phase 3A trial. And the protocol defines these two concepts known as estimands. They have a treatment policy estimand and a trial product estimand. An estimand was a concept that I wasn't very familiar with prior to reading this trial, and it seems that they use this across all of the Pioneer trials, but it was developed by a group known as the International Council for Harmonization. And essentially, it defines what you need to address to answer a specific question in a research study. For this protocol, the treatment policy estimand is the same thing as defining an intention to treat analysis. The trial product estimand, on the other hand, excluded patients who received a rescue medication, so which is very similar to a per protocol analysis, or only analyzing patients who received therapy that they were assigned to. Patients were assigned 2 to 2 to 1 to oral semaglutide, subcutaneous liraglutide, or placebo, in addition to their existing treatment for diabetes. Patients were either on metformin alone or metformin with an SGLT2 inhibitor, and they were stratified based on their baseline therapy as well as their country of origin. This graphic demonstrates the dose escalation schedule that was followed for the agents. Notably, the liraglutide dose titration happened much more rapidly than the oral semaglutide. By week 2, patients on liraglutide were at their maximum recommended treatment dose, but this didn't occur with the oral semaglutide until week 8. Patients were continued on their maximum tolerated dose for the remainder of the trial, which is up to 52 weeks. Also of note, there were very specific administration requirements for the oral semaglutide product in spite of having the snack additive meant to enhance absorption. So patients were told to take the drug in the morning, 30 minutes before their first meal and other medications, and with up to 4 ounces of water. So pretty stringent requirements for administration. Patients were able to receive rescue therapy or additional glucose-lowering therapy if they were persistently hyperglycemic, which they defined as having a glucose greater than 240 between weeks 8 and 13, or greater than 200 for week 14 and beyond, or an A1C of 8.5% from week 26 and beyond. Patients were frequently monitored and followed up and had many endpoints collected, including glycemic control. And they all used the same glucose meter that was provided for the purposes of the study, so everyone had the same meter. They also had their weight and A1C measured, lipids in other labs. They completed a treatment satisfaction questionnaire, an ECG, and they had a physical exam. The complete list of inclusion and exclusion criteria is available in the supplement, so this isn't an all-inclusive list, but I just wanted to highlight some of the concepts here. To be included, patients had to have been at least 18 years old, have an A1C between 7 and 9.5%. They had to be diagnosed with type 2 diabetes at least 90 days prior to screening and have been on a stable dose of their baseline diabetes therapy for that time frame as well. Patients were excluded if they were taking any other medication other than the metformin, the SGLT2 inhibitor, or short-term insulin within 90 days of screening, if they had renal impairment, which they define as an eGFR less than 60, history of acute or chronic pancreatitis, as well as history of major surgical procedures that involved the stomach that could potentially affect the absorption of the semaglutide. The primary endpoint was changed from baseline to week 26 A1C, which was a pretty standard across all the Pioneer trials. And a confirmatory secondary endpoint was set from change from baseline to week 26 in body weight. They also assess a lot of supportive secondary endpoints, so many that I couldn't even fit them all on this slide without making it completely overwhelming. I won't read them all to you here. This is just for your reference. Essentially, a lot of the other secondary endpoints that they looked at were the same as the first 2 mentioned, just at different time points, or a very similar endpoint such as achievement of a target A1C. We used the weighted Bonferroni closed testing strategy for 5 confirmatory hypotheses, and this was intended to reduce type 1 error because when you're looking at multiple endpoints, it's more likely that you might find a signal that isn't necessarily there. This was meant to mitigate some of that risk. And the way they went about their confirmatory hypothesis testing, for example, is that they had to demonstrate superiority in A1C lowering for the oral semaglutide versus placebo comparison before testing it versus liraglutide. They used ANCOVA for continuous data and logistic regression for binary data. They used a pattern mixture model with multiple imputation for missing data and set a non-inferiority margin of 0.4%. You can see on the right-hand side of the screen here the progression of patients throughout the trial. They screened and enrolled between August of 2016 and February of 2017 and ended up with 711 patients that were randomized. Overall, they had a very good completion rate. Between 94 and 97% of patients in each arm completed the trial. Here's select baseline characteristics. Again, I didn't include all of them. You can reference them in the original article if you'd like, but there are a few things I'd like to point your attention to. There's a majority of patients who were white, so 73, 75, and 70% white in each arm. And the mean or the average A1C was somewhere around 8 for all the groups. They had a duration of diabetes longer than 7 years. So these are patients who we would be looking for additional A1C lowering in anyway. And about a quarter of the patients were all on an SGLT2 inhibitor. This graphic demonstrates the primary outcome, which as a reminder was A1C lowering at 26 weeks. And this is for the treatment policy estimand, which is similar to the intention to treat principle. I will note that the trial product estimand did demonstrate very similar results, but I'll be focusing on the treatment policy estimand because typically we like to see the intention to treat analysis. So the green line is the placebo, and you can see that there wasn't much A1C lowering in that group, which would be expected. The blue line is the oral semaglutide, and the reddish pink line is the subcutaneous liraglutide. You can see that there was a more rapid decline in A1C with the subcutaneous liraglutide group, and this is likely due to the more rapid dose escalation in this group compared to the oral semaglutide. But at about week 14, they even out and remain about steady throughout the remainder of the follow-up period. Let's put these results a different way and give you some numbers. The mean change in A1C for the oral semaglutide group was 1.2%. For the liraglutide group, it was 1.1%, and for placebo, it was 0.2%. When we compare the treatment difference between semaglutide and placebo, we see that it is well beyond that non-inferiority margin, which was set at 0.4. So because of this, we can state that semaglutide was superior to placebo when analyzing the A1C change. But for liraglutide, it didn't cross the non-inferiority margin, so we can only say that it is non-inferior, not superior, compared to liraglutide. As I mentioned, there were a lot of secondary outcomes. I'm only going to present a few of them here. Notably for change in weight loss, the semaglutide group did better than both the placebo and liraglutide group at week 26 and 52. So compared to placebo, it resulted in almost a 4 kilogram difference in weight loss. With liraglutide, it was 1.2 to 1.3 kilograms. And then as far as sustaining the A1C lowering at week 52, we can see that it was significantly greater of an A1C reduction versus both placebo and liraglutide. The safety profile of the oral semaglutide was very similar to the other GLP-1 agonists that we are familiar with. The only difference in this trial was that there was an increased finding in GI adverse effects compared to the liraglutide group and, of course, the placebo group. Overall, though, the severe adverse effects were similar across all groups and weren't very frequent anyway, but it is something to keep in mind for clinical practice that you might see more GI adverse effects with the oral product. The authors concluded that oral semaglutide was non-inferior to subcutaneous liraglutide and superior to placebo in decreasing the A1C at week 26. They also concluded that it was superior in decreasing body weight compared to both the liraglutide and placebo, both at weeks 26 and 52, and the safety and tolerability was consistent with the injectable GLP-1 agonists. Overall, I think that they did a nice job of designing the study and answering a relevant clinical question. We know that with such a novel agent, it's really interesting to compare it to an active comparator in the same class. That's just a different route of administration. I do think that the use of the estimates concept slightly impaired the readability and comprehension of the study at first glance, but when you view it as more of a sensitivity analysis and that their results were similar between the two estimates, it enhances our confidence in what they found. There is a concern for generalizability and outcomes in real-world practice based on a few factors. One, the study population being predominantly white. We don't necessarily know for sure that we can extrapolate all findings to all patient populations, as well as the strict requirements for oral administration of this drug. As I mentioned, it was meant to be taken 30 minutes prior to eating and taking other medications. They can only have a few sips of water. So once we send patients out on the real world, on this medication, we may not see as significant of A1C lowering if they aren't able to maintain that stringent administration requirement. The additional outcomes that they assessed were likely unnecessary based on the prior pioneer trials that had been completed. They probably could have stuck with just 2 study arms, so just the semaglutide and liraglutide, as semaglutide had previously been compared to placebo, so we would have already expected to see a treatment difference there. Additionally, having all of the secondary outcomes that they were assessing increased the likelihood of detecting a signal in one of them. And I also think that perhaps the most clinically relevant outcomes that most providers may want to know about is the A1C lowering and weight loss. So if they had focused more on those, they didn't necessarily need to test additional secondary endpoints. As many of you may be aware, oral semaglutide was approved by the FDA in September of last year. It carries the same indication and black box warnings as the injectable product, and I'm told it's also priced the exact same way as well. The results of this trial did confirm that it is superior compared to placebo and established that it's non-inferior in A1C lowering and superior in weight loss compared to the subcutaneous liraglutide. However, the A1C lowering wasn't as significant as some of the trials that the subcutaneous product demonstrated, which was interesting. The potential place in therapy for the oral semaglutide could be an alternative option to the injectable agents when we're looking for additional glucose control. As I mentioned, there wasn't any evidence supporting a cardiovascular benefit, so that could further narrow the place in therapy for this agent, especially when we do have certain GLP-1 agonists that do have that benefit. So we'd only really want to use it if we're looking for additional weight loss or blood glucose lowering. Insurance coverage, though, will probably continue to dictate which agent patients receive. As we know, this is the common practice that you try one agent and then it's not approved by the insurance, so you switch to another one. So that could also potentially be an issue for the oral semaglutide product as well. I would like to thank Logan and Catherine for all of their help with my references, and I will take any questions now.
Thank you, Stephanie. To start out, we do get a question from Hannah. We appreciate the question. Kind of an application here. Let's say you have an adult female patient with type 2 diabetes. Her A1C is currently at 8.5, metformin is maximized, does have a history of MI 5 years ago, wants to start a new drug to decrease the risk of that ASCVD events in the future. She's willing to using an injectable medication, but would prefer an oral drug. Would you recommend oral semaglutide to reduce the risk of ASCVD?
At this point, based on the data we have available, I don't know that I would. I do think it's interesting that the injectable product seems to have a benefit, but the oral product so far hasn't. I believe in the Pioneer 6 trial, there was a slight trend for lower events, but it wasn't statistically significant. It's not, you can correct me if I'm wrong. So at this point, if the patient was open to trying an injectable, I'd probably recommend that instead.
Yeah, good answer there. But it kind of leads you into the next question. Have you seen any insurance plans covering oral semaglutide yet?
I personally haven't. I know anecdotally we had talked about a few patient cases where they required trialing an injectable GLP-1 agonist first before they'd approve the oral. But personally, I haven't seen it being used yet. I'm not sure if anyone has any different experiences.
Yeah, I'd be interested to hear from everyone else to see if that is something that other people have dealt with. I know it's been on. I know in my clinic personally, I've had questions on it, but usually it doesn't go very well. Next question from Eric. We got, what CV outcome studies are ongoing with oral semaglutide, or is there any going on?
I'm not aware of any that are ongoing. I think Pioneers 9 and 10 are also just kind of like dose response studies, so not particularly looking at any cardiovascular outcomes. At this point, I'm not sure that there are any.
Yeah, I'm not sure of any as well from my end at this time. Thanks for all the questions. Rolling down through those. Looks like some people are saying they haven't seen it covered in patients yet. Medicare patients, definitely not. Private insurances. For private insurance, the company does have a strong program for picking up the cost if insurance doesn't cover.
Okay.
So yeah, I know there are definitely programs, or I guess trial cards for the medication as well. Good. Jen says that there is a 5-year cardiovascular outcome trial ongoing right now, but it's about 5 years out, obviously, as we only have the one trial. It just probably started. Let's see. Any other questions from people? I do have one that I was going to ask. Oral semaglutide, has that been compared to the subcutaneous version?
Yeah, there was a phase 2 trial where they were compared. And interestingly, I believe it was more of a dose-finding trial, and the doses that they used of the oral product were higher than what was used in this trial. And in that finding, they didn't demonstrate any significant difference. They did find an A1C lowering up to, I want to say, 1.9%, which is slightly different than what was demonstrated here, but that could be due to the dose response. Other than that, I don't know that we have any great comparison data.
Okay. All right. Another question would be comparing this to oral or to subcutaneous semaglutide again. Are there any other patient populations that you try to avoid the use in it?
It does still carry the black box warning for thyroid tumors. So although there wasn't any major concern demonstrated in the safety data of this trial, I would still recommend avoiding those patients. There were, I think, 2 cases of pancreatitis, so you could recommend avoiding in those patient populations as well. And also importantly, when we think of controlling diabetes and various other patient populations, like patients with type 1 diabetes, it wouldn't be recommended. Likely patients who are transplant patients, we probably wouldn't want to use this agent, partly due to the strict administration requirements and the other amount of medications that they're on, but also because it just wasn't studied in those patients would be other reasons to avoid.
Okay. All right, any other questions from the audience? Seeing none, I think if anybody has any more, feel free to text into the box, but I think we'll hand it back over to Kylie.
Okay, thank you.
Great. Well, thanks once again, Stephanie and Logan Frank, and also Catherine Montag Schaefer for all of your work, and thanks to the whole group. We really appreciate everyone coming and attending and asking questions. And so this recording will be uploaded to the PRN's site and will be available shortly. And I'll send an email out to the entire PRN to watch this recording when it is available. So thanks again, and have a great rest of your day.